All right, thank you everybody for being here. I'm excited to close out our fabulous PHHP days. All right, as Dave said, I'm in our Department of Physical Therapy. I'm a researcher and I direct our collaboration, I'm going to say our relationship between our college and Brooks Rehabilitation. My career has been dedicated to serving people with spinal cord injury. I'm going to tell you a little bit about that today. So spinal cord injury is a complex disorder. So of course, I don't do this work on my own. I work with a team of individuals, many different clinicians, basic scientists, clinical scientists, engineers. Many of us come together. Collaboration is hard. It takes intention and it takes time. And often we might find ourselves working in silos. So today I'm going to share a story about some projects that we conducted that would not be possible without really bringing teams together and collaborating. Recovery is a team sport. We need to come together. My goal today is to motivate you to think about your teams, think about the individuals that you bring together to ultimately serve the populations that you work with. So first, a little bit more about spinal cord injury. Spinal cord injury affects individuals in many different ways, from impairments in breathing that we'll talk about today, an inability to sit up, an inability to use your hands, arms, and an inability to walk. This complex disorder happens in an instant. It's often due to trauma. It may be a car accident, it may be violence, it may be a bad hit, and even a fall. So many different causes. The thing about spinal cord injury is that every injury is different. Every injury is different because, of course, no two people hit a windshield the same way. So after spinal cord injury, a great institution like UF Health saves your life. But then ultimately, you go to rehabilitation where you learn to put your life back together. And teams of clinicians, PTs, OTs, speech, nursing, physicians, all come together to help an individual relearn the skills that they had lost. So in my career, I've had the great opportunity of not only working in our college, but with Brooks Rehabilitation. Brooks Rehabilitation is one of the leading rehabilitation health systems dedicated to care after that acute care period. It includes multiple hospitals and multiple outpatient centers. So I work across two institutions. So what that means is on any given week, let's say on a Tuesday, I'm at Brooks and I'm in the halls with clinicians and patients, and I'm getting feedback from them. I'm hearing about the gaps in care, the things that make their world easier or harder, the things that patients need. And then on a Wednesday, I have a great opportunity to be in the hallways with our colleagues here. So basic scientists, clinical scientists, discussing data, new approaches, emerging therapeutics, and things like this. What a great opportunity. So when I was starting my career, on a Tuesday, I stood in the hall at Brooks and I talked to clinicians, and what I heard was that they were challenged. They didn't have sufficient tools to address respiratory impairment after spinal cord injury. And this was really surprising to me because respiratory impairment is one of the leading causes of illness. I said every injury is different, but actually almost everybody with spinal cord injury has respiratory impairment. So this was surprising. What I was also hearing from them is that patients were coming from acute care to rehabilitation with a new device called a diaphragm pacer. So an implanted device that goes in the diaphragm to stimulate the breathing muscle to ultimately make breathing stronger and help patients wean off the ventilator. This sounds promising, except for rehab clinicians didn't know what to do with these patients. They thought they had to be extra cautious. That makes sense, right? They thought these patients were fragile, so they weren't maybe doing the standard care that might have been needed. On this Tuesday, I also talked to a patient with cervical spinal cord injury. So this ultimately means he had broken his neck. So take a look at this individual. This is the individual I talked to. He had broken his neck, And that means that the nerves from his spinal cord going to his breathing muscles had been impaired or damaged. His breathing was weak. He had had a diaphragm pacer. He had received a diaphragm pacer. He was unable to use his arms and hands. He was unable to sit up, and something like standing or walking was not even a goal for him. And you can appreciate some of this. Notice the the strap going across his chest. That was holding him steady in his wheelchair. So what he told me was that his breathing had gotten stronger, and he was able to go home. That's great. But now the diaphragm pacer was posing an issue, because the diaphragm pacer, this device, took batteries. The batteries were expensive, and he couldn't afford them. And that because he had this device, which was a life-saving device, he was not actually able to use public transportation. So this was a problem. But his breathing had gotten stronger. And so, you know what he did? He turned the device off. He unplugged it and disconnected it. So first of all, how brave is that? Okay. Secondly, that was amazing. That meant that his breathing had gotten so much better that he was confident and able to do this. So on a Wednesday, I talked to my colleague, Dave Fuller. Dave Fuller is an expert in respiratory function and spinal cord injury. He's my mentor and colleague. We talked about how is it that someone with such a severe injury was able to turn off this device, their breathing had gotten stronger, and make these gains. And so many of you know Dave, and he said, well, we can study that in a rat. We'll study that in a rat with spinal cord injury, and that's what he and his lab did. He, along with his postdoc, studied a rat with spinal cord injury. So what I'm showing you are signals from the diaphragm. So he planted electrodes into the diaphragm and recorded the electrical activity from the diaphragm. Then they stimulated the diaphragm, just like a diaphragm pacer, for just 1 hour. They turned the stimulator off and they recorded again. And here are the signals. They are bigger. They're more robust, they're stronger. So the diaphragm and the activity to the diaphragm had gotten stronger. This was evidence of neuroplasticity. So this approach had changed the nervous system. And so this too was amazing, okay? Good job, Dave, okay? All right, so you might think, I'm a researcher in PHHP. The next step is to apply for grant funding and move this forward and improve clinical care and help patients. But actually, no. My PhD was in walking control after spinal cord injury. At this moment, I had never even measured breathing in a human, okay? But this was a clinical problem. This was a major issue for our patients. And I'm in our great college of PHHP, right? So I have colleagues that are experts in respiratory control. I have expertise in spinal cord injury, and I also work at Brooks Rehabilitation. So I have clinicians and patients that are gonna show up to be part of this process. So with the support of our Brooks UF collaboration, I was able to pivot. And with this support, we wrote a successful SCI respiratory grant. This enabled us to study this in humans. We studied them in the ICU at UF Health. We measured their breathing. We recorded from their diaphragm because they had these wires in them. We followed them into rehabilitation, and we were able to obtain data that mimicked what we saw in the rat. We showed that breathing got stronger and the diaphragm activity also got stronger. We used these data and these experiences to go forward, and we put forward a model of respiratory function for recovery. So to help clinicians have the tools to think about respiratory recovery and to think about actually diaphragm pacing as an adjuvant to rehabilitation care. All of this was only possible because we have a very large, diverse team. Basic scientists, clinical scientists. We had the voice of people with lived experience telling us, hey, you can turn off that diaphragm pacer, okay? All of us came together. So now let's fast forward. Tuesday, maybe 2 days ago, right? So now I stand in the halls of Brooks Rehabilitation, and what I hear from clinicians and patients is that they want clinically accessible tools. They want tools to make rehabilitation stronger, things that can easily integrate into the clinic. Okay? They want more bang for the rehab buck. Now on a Wednesday, I talk with my colleagues and we talk about new strategies. Therapeutic intermittent hypoxia, a very elegant strategy just that involves breathing brief periods of low oxygen to stimulate the nervous system and promote plasticity. We talk about transcutaneous spinal stimulation, just putting electrodes over the skin, over the spinal cord to activate the spinal cord and help it respond more to rehabilitation. So now, on Thursdays, we get to conduct clinical trials where we test these therapeutic approaches. We test it in breathing, in coughing, a critical function, walking ability, trunk control, all of these functions. Now our team also includes SHARP. SHARP is our spinal cord injury health research partnership. This is a group of individuals dedicated to bringing clinicians, researchers, and people with lived experience together. It's a group of individuals dedicated to ensuring that people with injury have the opportunity to have a voice in research and ensuring that research is not conducted without their voice. Again, all of this was possible because we brought a diverse team together. So I challenge you to think about your team. How do you show up for your team? Are there others that you should be reaching out to bring into your team? Okay. Ultimately, recovery is a team sport. Thank you so much for the opportunity to be here. And thank you for all the people that contribute to this work, truly.